We're going to get started. Our next speaker hails from Brooklyn, New York. Medical Director at Chesapeake Vascular Access. He is a past fellow of the American College of Surgeons. He is a Vascular Access Board certified and a past president of AMA. It is with great pleasure that I introduce Dr. Jacqueline Hahn.
Thanks. Thank you, Darcy. So I'm going to start off with two stories. If I'm telling stories, I'm never going to get finished. Russ, give me the signal. Oh. Thank you. Thank you. If I'm telling too many stories, give me the signal, because otherwise we'll be here for a good long time. So story number one is, I was at this meeting last year, and my sponsor, we went into the CPMC Sutter campus, and I love that's why I asked that question earlier, and I love the vascular access nurses at CPMC, and we're rounding, and the lead, I can't remember her name, we're passing a room, and there's a doctor in the room writing her note on Epic, and she goes, oh yeah, go in and talk to that doctor. So I'm saying, gee, that's not how this works, you know, like it was an ambush. You know, and I know an ambush when I see one, you know. So I go in, I'm saying, what am I going to talk to this doctor about? So I said, let me start like, you know, we put the jugular catheters low in the neck. And she's there, no. We like to go as high as possible. Have you ever heard of pneumothorax? And like, I ran the chest tube service in my hospital, so I have heard of pneumothorax. You know? So we're going back and forth a little bit. And so finally she tells me, okay, I'm going to start putting them low in the neck. That was to get me out of the room. She's not going to put them low in the neck. The other story I want to tell before I start, there was a lady named Suzanne Herbst that was in San Francisco at the height of the AIDS epidemic. The AIDS patients had vascular access, but whenever they developed an infection, the doctors would yank the vascular access. And Suzanne found, like, well, that's not helping very much. The problem was all the AIDS patients had fever. So they were all getting their lines removed. So all the things you see out there in the lobby, they weren't available in the late 80s. It took Suzanne, like her ideas, to gel this, like the knowledge base and the equipment that was there. So I was fortunate enough to have been awarded the Suzanne Herbst Award, as was Matt Ostroff, Marcia Ryder, and Nancy Moreau. We're all recipients. You guys weren't there. This is Suzanne handing me the Herbst Award.
I'm giving you this container for your ashes.
Dr. LeJohn getting the Suzanne Herbst Award, right? All right, so this is what we're going to talk about today, a topic that's not spoken nearly enough, this relationship between the way we put in these lines and the way the nurses can care for them, right? So I do speaking for the following companies, so that's my disclosures. I'm biased. So, you know, when you're biased, right? So what's the goal in all this? The way I see it, we're trying to standardize practice at the highest level because we work on human beings. So standardizing practice, like it's systems analysis, Toyota manufacturing, the airline. We're not learning medicine anymore. We're learning this other stuff. What do you get out of it? I have my biomedical engineer here. He knows about standardizing practice. What do you get out of it? You hear about this. What do you get out of standardizing practice? It can eliminate unnecessary variation. And what do you think unnecessary variation does to your outcomes? Nothing good. So the problem, as I see it, now I'm going to show a lot of my stuff. There's a hospital in my hometown, which I consider to be the world epicenter of venous depletion because of the scourge of IV heroin in that community going back for decades. So they really know how to deal with venous depletion. So I'm going to show some clips from my lecture there earlier this year, right? So basically, do we want a dressing that requires frequent changing or stays intact for 7 days? And this is going to be a little interactive. You know, the more you interact with me, the better it'll be for me. Like, this might be the most important thing that the inserter does to prevent infection. Nancy Moreau brought up, like, that insertion bundle, 5 things. It doesn't talk about it doesn't say a word about the dressing or the way we insert the lines. It might be the most important thing that we do to help prevent infection. Is it better to have a dressing that requires replacement, or one that stays intact for 7 days. And that one picture was furnished by Matt Ostrov, the other by Evan Alexandra. I mean, like, these are things that you just have to look at and use your common sense and what some of the stuff that's in the literature. The problem as I see it is that central lines are inserted suboptimally. The dressings are not intact times 7 days. And the never event, CMS declared this a never event. The last year I have data for 2023, it occurred 250,000 times. So if that sounds like never to you, fine. It doesn't sound like never to me, right? But are these facts related? We're putting in the lines crummy, the dressings aren't staying on, and they're getting infected, right? Suppose the RN or the infection prevention is fined a disrupted dressing. What are they supposed to do? Change the dressing, thank you, right? Of course, this is like all over the infusion therapy standards, right? But I called Lisa Gorski to talk about this last winter, and she called me back. She says, yes, Jack, the dressing has to be changed, but we have to ask why is the dressing, why is it being disrupted? I mean, like, because you can change it this shift, you can change it the next shift, and you can change it twice on the shift after that. Unless we get to why they're disrupted, we're not going to solve this problem, right? So disrupted dressing. It's a deviation from optimal care. Like in the operating room, if there's a break in sterile technique, everybody puts up with their hands and walks back from the table, and the OR tech puts sterile towels down, kind of thing. We have to recognize that a disrupted dressing is a deviation from optimal care. Exposes the patient to the toxic environment in the ICU, right? And how long do you think a dressing, if you find a dressing disruption, how long is it disrupted for? 18 minutes, 34 minutes? It might be 2 shifts. That patient's being exposed to that toxic environment for 2 shifts, right? It's waste. What do I mean by waste? Nursing time, cost of supplies, increased risk of infection. Nursing time is a valuable commodity in a hospital. The nurses aren't supposed to be wasting their time changing dressings unnecessarily. And the thing about waste is you expend resources and you don't get anything for it. So lean principles, we want to eliminate waste or convert waste into value, right? So, has anybody in the room seen something like this? Raise your hand. A show of hands. Okay. All right, good. Right? Who doesn't like it? No, people. We're the vascular access community. We shouldn't be seeing this, right? And we don't like it. The vascular access community doesn't like it. So why is it going on? Tell me, why is it going on? We've all seen it. We all see it every day. Like, why is this going on? Right? Yeah. Yes. We're the vascular access community, right? So according to me, the state of acute vascular access in the United States is deplorable. And to me, my son affectionately calls this the mess on the neck. And I like that terminology because it conveys what you're seeing, right? This is what incipient CLABSI looks like. Like, I don't need a positive blood culture to tell me this isn't good for the patient, you know? And if you found something like this, and this is the heart of the problem, right? If you found something like this, what would you do with it? Is there a door you can knock on to say, hey, do you see what's going on in bed 6 in ICU? It's a mess down there. There's no place to go with this stuff, you know?
You're a lawyer.
Yeah. So basically, somebody has to be in charge of vascular access. Matt Ostrov is in charge of vascular access in his hospital. I was in charge in my hospital. We eliminated a lot of this stuff, right? But something is wrong. Something's wrong. If this stuff is tolerated, the doctors don't even see this, right? So, like, what can you infer about the inserter? And let me go on the record. If I need my central line dressing attached to my earlobe, I want that person to do that. Look at that. Look at the way it's lying flat. There's no pleat. That's what an earlobe central line dressing is supposed to look like, right? But what can you infer about the inserter? He needs remediation. You can't, you know what I mean? What about the guy that trained him? What can you confer about the trainer? He shouldn't be training people, right? And suppose the ICU director comes in Monday morning. He didn't do it. It's not on him, right? But if he goes home Monday afternoon, then it is on him. Like, should he fix it or should he leave it? What do you think? You think there's any literature on that? You ever try to convince a doctor to do it? Show me the paper. Show me the paper, right? So I'm in a hospital in New Jersey I was there for 3 months 2 years ago, right? And to help them with these, The chief medical officer told me a number of times that heads were going to roll if they didn't get CLABSI under control. And what I think he meant was his head was going to roll. You know what I mean? So they actually brought me in there for a long time. So I'm rounding in the ICU with decision makers, and that's the key. And with the chief medical officer, the chief of the ICU, right? You know, and we find this thing. So like, I pitch a fit. You know what I mean? Like, I'm being nice. I'm a guest. No, you know, you look at like, in other words, like, you can't have stuff like this. And like, well, where we get a CLABSI? They had 48 CLABSIs the year before. It was a 650-bed hospital. I mean, like, if you have stuff like this and you're there, like, we don't know where the CLABSIs are coming from. You know what I mean? So 2 days later, after I pitched my fit, that dressing was still intact, right? So I'm in the coffee shop with my son when the director of the ICU walks by, and I called him over for a little conversation that went like this. Hey, Dr. Blake.
Yes.
You know that patient we saw 2 days ago with the central line dressing attached to the patient's earlobe?
Yes.
That line is still in place. It kind of indicates to me that the leadership of the ICU is willing to tolerate a poor quality of care.
And by the leadership of the ICU, do you mean me?
So let me go on the record and say that didn't work out for me. You can't tell somebody straight to their face that they're tolerating. So I have to learn too. You know, go around, like, you know, there's different ways probably Dr. LaDunn, but, you know, on one hand, it's a major problem. But, you know, like but on the other hand, it gives us a point to deal with this thing, right? And you can't fix the problem if nobody accepts responsibility. Somebody's got to really be in charge of vascular access, especially at a large institution like this one or UCSF or, you know. So today, my focus is going to be on process. Not on outcome so much, but on process. And the great Takashi Osada put it like this. If the process is right, the results will take care of themselves. Do you know how many institutions I've gone to and you find the mess on the neck, the mess in the groin, they tell you, oh, we don't have a CLABSI problem. I mean, it's all over. I mean, it's ridiculous. Like, you know, their outcomes depend on your process, and I find crummy process wherever I go, right? So why do MDs insert suboptimally? Essentially, I think this is the heart of the question. You know, like, why do they do this? So, like, this is something, like, I asked them, what is your guiding philosophy regarding central venous access? Now, this is something that's rarely spoken about and never written about. What is your philosophy of practice? But it's vital, right? This is Faisal Masood from Houston, Texas. We have to make it easy to do the right thing and hard to do the wrong thing. Yes. Dr. Pittarudi puts it like this. We have to do the right thing for the patient and not what's convenient for us. Told me we have to avoid pneumothorax at all costs. And mine, as I put up earlier, was we have to standardize practice at the highest level because we work on human beings, right? So what do MDs do or not do if avoiding pneumothorax is their guiding principle? And all right, a lot of these things I ask you are going to be extra credit questions. Some I'll have to deduct for, but this will be an extra credit question, but I'm going to go into it, right? They won't use the chest. Subclavian, what's actually the axillary vein, I'll get into that a little bit. They won't do it. If they're trying, if they have to avoid pneumothorax, they're not going to do this. They'll use the internal jugular vein exclusively, and they'll go high in the neck. That's what you do if but that's why your guiding philosophy is very important to, like, direct your practice, right? So I'm going to discuss 3 papers briefly. I'm going to discuss Tim Zitt's paper on dressing disruption, Annette Richardson on dwell of the dressings, and Christy Gaskell on improving maintenance of central line dressings, right? So basically, do we need a paper to tell us that this isn't good for the care of the patient?
No.
No, but you ever try to convince a doctor without a paper? Like, show me the paper. And like, hey, look, I went to medical school. What is that green line, the adhesive tape on the hair behind the ear, doing for the patient? Somebody tell me how that's helping the patient, right? But like, show me the paper. Show me the paper that this isn't good. Well, okay, here's the paper. This is Jean-Francois Timsit, the famous French intensivist, talking about dressing disruption as a major risk factor for infections, right? Timsit found that 67% of the dressing changes were unscheduled. How does that number sound to you? It's pretty bad, right? And if a dressing was disrupted, the risk of infection or colonization went up by a factor of 3. If the terminal dressing was disrupted, it went up by a factor of 12. And Timms had found that subclavian, quotes, access protected from disruption, right? Paper number 2, this is Annette Richards from the UK. So how long is a central line dressing supposed to stay intact? 7 days, thank you. We're interactive here today, right? How long are they lasting? Unless you're doing a research protocol in your institution, you won't have the answer to this. But that's why we read the literature, that's why we write the papers. So Richardson found the following. So these are 4 dressings. We're familiar with all 4 of them over here from the UK. The best one stayed on for less than 3 days, and the other 3 stayed on for less than 48 hours. Pretty good, huh? They're supposed to be on 7 days, and they're not on for 2. People, this is a smoking gun. Unless we fix this, like, what's the sense of having an infection prevention program if we're not having dressings that stay intact? It doesn't make sense, right? So how can we improve duration? I've elucidated the problem here. These lines are being put in poorly, and people are getting infection. What's the solution to this? How do you prevent a dressing disruption? Number 1, you insert the catheter properly. There's no way around it. Number 2, 3, 4, and 5 is the same thing. Of all the things that you can do to prevent an infection, like, this may be the most important thing, right? The exit site is crucial. Like that washing your hands and draping the patient and correcting the skin prep. It's important. It's temporary. The exit site is crucial and it's permanent. Whatever happens, whatever outcome you get from that line is going to be dependent on a proper exit site, right? And I like to use a dressing adhesive. I want to put in the line properly, good exit site, and I want to glue it down so that it stays intact. Now, if you're an OCD note taker, be my guest. We'll send you the PDF of this. We'll send you the video of this, whatever you want. You want to take notes? Be my guest. Right. All right, the infusion therapy standards. This is I put in here the 2024, but it may not be. It may have been removed from the 2022. Evaluate the beneficial use of a gum mastic liquid adhesive when enhanced adhesive adherence is needed. Now that's a mouthful. What Dr. Ledun says, you just want the dressing to stay on. I want that dressing on. I don't want it invaded for 7 days. I don't want the nurse spending her time changing the dressing, right? So what is gum mastic liquid adhesive? It's the gum of the mastic tree, which grows on an island in Greece. Little volume here, Billy. It drips from the bark of the tree. How do you not use something like that? Are you kidding me? There are other uses for this stuff, but today
it's very sticky. When it dries, it helps so I'm just going to trace this, just like this.
That's the immortal Matt Gibson from Kentucky. We're not all Matt Gibson, but we can do this. We can do this. Like Matt, you know? Okay, this is the 3rd paper. So the first paper was Timms. Dressings aren't staying intact and it's leading to infections. The next one was Richardson. The dressings are only staying on for like 48 hours, right? But we didn't have a paper that showed what happens if you use the gum mastic liquid adhesive. Now, Christy Gaskell did this paper. So their initiative supports the evidence that a clean, dry, and intact central line dressing can be an indicator of a patient's risk for CLABSI, sure. She found that the CVAD dressings were compromised by lifting and peeling 63% of the time, her data, 82% bleeding rate. Now, I don't know what to say. My bleeding rate was 2%. So I started to think, what did I do? So I didn't cut the skin, and I used micropuncture equipment, among other things. I don't know why she had an 82% thing. The average length of time the dressings were dwelling were 2.7 days, in line with the Richardson study, right? So then so basically Gaskell goes on the list at 65 hours, you know, for hers. So they introduced gum mastic and also some hemostasis. You had to, you know, with an 82% bleeding rate, you needed some hemostasis. So what did they find? The dressing integrity was improved dramatically. The dressing life improved from 2.7 days to 6.5 days. Now we're doing something about the problem, right? It's closing the loop. We didn't have this study before, and there was no MARSI detected in her study, right? So the way I deal with this issue is what I call the life cycle of the central venous catheter, with the goal of standardizing what we're doing at each phase of the life cycle. So there are 5 phases: assessment phase, vital, pre-insertion, actual insertion of the device, dressing, care, and maintenance, and the removal. Anything good or anything bad happens in one or more of these phases, because that's all there is and that's all there'll ever be. And another way to look at this is the chain of CLABSI prevention, and the chain is only as strong as its links. So basically, phase 2 is the insertion bundle. As Nancy Moreau elaborated, it's standardized around the world. What you're doing in San Francisco is what I'm doing in Baltimore, is what they're doing in Sydney, Australia. Evidence-based, standardized around the world. That's what we have to do for the other phases. Now, I'm not going to talk about assessment just for time thing, but we have to assess the patients in standardized fashion as well, so that we're all coming up, you know, like with what is the proper line or selection. You might have a selection of lines that are appropriate for this patient, right? But getting on to phase 2, which is standardized around the world, originally described by the CDC and the Institute for Healthcare Improvement, and validated by the Keystone Report, as Nancy elucidated, Dr. Peter Pronovost, Johns Hopkins Anesthesia, New England Journal of Medicine, December 28, 2006. This phase lasts from the time you do your hand hygiene until you drape the patient, the pre-insertion phase, right? The HCPAC committee in Washington asked me to rewrite the insertion bundle. That's baloney, of course, but what I did was, in my rewrite, I removed daily review of necessity. Why? It has nothing to do with the way we insert a catheter. It's clearly a care and maintenance practice. But when they wrote up that paper in 2006, they didn't know where insertion stopped and care and maintenance started. The other change I made was, instead of avoid the femoral site, as Matt was showing, it's avoid the groin. The femoral vein goes from the groin to the knee. The middle of the thigh, the lower thigh is not the problem. The groin is the problem. My point about this, and when Nancy was going, you know, I showed, this thing in Pronovost's paper showed a 5-fold decrease in the CLABSI rate. It takes 90 seconds to do it. I'm here to tell you there's much more to vascular access than these 90 seconds. I'm not saying this is unimportant. That's not my message. But like, don't tell me if you do these 90 seconds right, you're going to get a 5-fold reduction. It was crazy in 2006. It's ridiculous in 2026, right? So today I'm going to discuss 5 procedures. These procedures. The first one is the mid-thigh femoral, as elucidated by the father of it, Matthew Ostroff, right? And this is his paper. I mean, just look at it. Like, you just have to, I want people to go to the foot of the bed, the inserter and the nurse, and look at what you've got. And like, you want a mess in the groin, or you want something that looks like this, right? And this is how you do the procedure. So I'm about 14 centimeters below the groin crease. We're using micropuncture equipment. We don't incise the skin. The skin is the natural barrier to infection. You don't have to incise the skin.
Right. Good.
Sutureless securement, always.
I'm just going to come out.
All right, so moving on from the pre-insertion, the standardized thing, we come to the actual insertion of the device. And my motto for this phase is insert the catheters properly. And it's ridiculous that you have to say that in 2025, but you do. So I'm an inserter. This is the fun part for me. This phase lasts from the time you drape the patient until you put on that dressing. When I put in a line in ICU and slap on that dressing, by definition, the patient is now in the care and maintenance phase, right? So we want to figure out what are the best practices in this phase, then standardize the procedures at that level, right? So basically, there are 5 phases to this thing. These 4 account for 1% of the life of the catheter, and the dressing and care and maintenance phase accounts for 99% of the life of the catheter. So if you're going to affect the infection rate, would you deal with the little orange sliver or the big blue pie? The action's clearly in the big blue pie, but they're related. The way the nurse can care for these lines depends on the way we insert them, and the doctors have to learn this lesson, right? So I talk about a proper insertion. What am I talking about? Number 1, minimal attempts, hopefully 1. Number 2, we want the tip close to the cavo-atrial junction. I'm just going to say, For those, that's nothing new to the people in this room, the vascular access community. There's a counter narrative from the emergency department, anesthesia, and critical care. They don't believe this. And they've got literature, they've got their studies to show it, but we believe that the catheter, the tip belongs at the cavoatrial junction, right? I want to have a proper exit site. And it comes down to this. The ear is bad and the chest is good. Sutureless securement, antimicrobial protection, and I want that dressing to stay on intact for 7 days without reinforcement and without adhesive tape, right? Where are we? Phase 3, I say there are 16 decisions, there are choices, and these are my recommendations. So in other words, if you say like, I'm gonna nick the skin, you made a decision. Right? If you say you're not going to use ultrasound, you made a decision. You may not even realize you're making these decisions. I'm not going to go through all 16 individually, but I'll show them in the videos that we show, right? This is the paper that I'm reading, and Matt Ostrov brought up Dr. Pitteruti is the second author on there. This is basically all the stuff I talk about is going to be contained in this paper today, right? So what do MDs do or not do if avoiding pneumothorax is their guiding principle? I think they won't use the axillary vein. Did I go into the slide already? Did I show this? No? All right. They'll utilize the IJ vein exclusively, and they'll go high in the neck, right? All right. 16 decisions. Number 1 is ultrasound always. Number 2, where are we going to place these central lines? And I asked the doctors, what is your go-to site in the ICU? And they tell me jugular vein. Mine is the axillary vein, ultrasound guided axillary, right? For those of you who haven't been doing your radical neck dissections lately, that's the internal jugular vein. Like, what's my beef with the jugular vein? If I walk through your intensive care unit, I guarantee I would find some internal jugular vein action, right? But what's the beef? Like, what's it ever done to me, right? There are too many ways to do it poorly, not inserted in standardized fashion. Unnecessary variation, right? So in other words, you can put it high in the neck, you can put it middle of the neck, and you can put it low in the neck. Vascular access experts of San Francisco, where do you want it? Which standard, where do you want it? You want it low in the neck. Anything else, any other place is not standardized at the highest level, right? So like Dr. LeDun, IJ vein principle number 1 is low in the neck, and I consider that to be mandatory. I was at the hospital of world epicenter of venous depletion, and I was lecturing on this, and I had my camera in the audience, and they had a running commentary. I didn't know who was lecturing, them or me, right? So I'm bringing up my points, and this is what they're saying. Dr. LeDun, principle number 1 for the internal jugular vein is low in the neck, and I consider that to be mandatory. If we're going to standardize this at the highest level.
That's interesting because I was never told like that. I was always told high. I was always told to go high because I'm scared of the new one. Exactly. Yeah, well, you get more.
I hope to get it before ultrasound.
Ultrasound. I used to put it high because it was scared.
CLABSI is a bigger, badder infection than pneumothorax will ever be. Okay. That's how the whole lecture went. It was a battle. I mean, like, that was the chief of surgery. Pretty soon the residents were getting on my case, you know what I mean? So I want to talk to you today about the catheter dressing as a unit. So in other words, the catheter has to exit from the dressing. You can't just coil up the catheter underneath the dressing like a rattlesnake. The nurse can't use it, right? So here's a typical jugular vein placed catheter, right? So the catheter can exit from the dressing north or south, east or west. So let's say the catheter exits from the east side of the dressing. You might get a configuration like this. Now, you know, I always say, what can you say about MDs? Like, they're not all nice people. They don't all have a sense of humor. They're intelligent. As a group of people, they're intelligent. So here's somebody that graduated from medical school that put a dressing on the patient's mouth, widely described as the dirtiest part of a human being. Like you were smart enough to get in and out of medical school and stupid enough to do this. Now, you can't go to the library and look this up, that this isn't good for the patient. I'm there like Dr. LeDun didn't know exactly what to say on this one, right? Or you can exit it from the west side of the dressing. And like, you might get a configuration like this. hey buddy, the hub's supposed to be covered, you know, just the way we do it in Brooklyn, we cover the hub. Okay. The classic is the doctor goes to the head of the bed, sticks in the catheter and directs it north, and the catheter exits from the north side of the dressing, and you might get this little mess on the neck configuration according to my son, right? Or you can have the catheter exit from the south side of the dressing, and it'll look like this. What is the goal? Standardizing practice at the highest level, right? So, which configuration standardizes practice at the highest level? Yeah. And so what will the doctors tell? Anything else? Any other way isn't standardized at the highest level. You got to learn this, right? So what are they going to tell me for their reason not to do this? What are they going to tell me? Extra credit question. I'm not going to deduct. They tell me it's going to kink. You know what I mean? Like, so somebody that hasn't done this procedure is going to tell me, who's done it 7,200 times, that it's going to kink. I'm waiting for my first kink, buddy. Like, I love being told stuff by people that don't do the procedure. It's really my favorite thing in the whole world, you know? So, IJ vein principle number 2 is rotate it down, right? Principle number 1 is low in the neck, rotate it down. I come from the side of the bed. That's the only way I do it, the only way I teach it. But I don't consider, like, if you can do it from the head of the bed, fine. So I don't consider that mandatory, right? And this is what I'm talking about.
Hold this thing down toward the chest, not up near the ear. Good work. Okay, I do not want this dressing up near the middle of the neck. I want it down toward the chest where it belongs. So we're going to put it on with the slit facing the catheter, and we're going to offset it up just a small amount, maybe about 10 degrees. Let the catheter, all right, we're going to do the skin prep. Okay, so we're going to take off the rest of it.
All right, so Lisa Gorski, people in the room, why is that dressing disrupted? I've given you the answer, just think about what's there. Somebody tell me, why is that dressing disrupted? Say it. Yes, Augie, yes. The catheter comes out the top of the dressing, it's facing north. Gravity grabs the tails and pulls it toward the floor, right? In the patient I just showed, the tails are coming out the bottom of the dressing, gravity's working with you. This is the way it has to be done if we're going to standardize this. So back to the epicenter, world epicenter. So the resident there rotate from Columbia University to this hospital. Now the resident's getting into it with me, right? We're talking on this point. But she was good. If you find something like this, what do you have to do?
You have a new dressing.
You have to change the dressing, fine. But you have to ask, why is it disrupted? Yes. The catheter exits to the top of the dressing. Gravity grabs the tails and pulls it toward the floor. The patient I just showed, the tails are coming out the bottom of the dressing, and gravity's working with you. You can fight gravity because somebody trains you to go to the head of the bed and grab it up. Go ahead. But the dressing's not going to stay intact. If you don't think the dressing's important, do it that way, right? I love the interactivity, you know, I just do, you know. So why do MDs insert high in the neck? What's their guiding philosophy? They're trying to avoid pneumothorax at all costs, right? So basically, the internal jugular vein goes from the mandible to the clavicle, right? And inserting high in the neck is a passive technique to avoid pneumothorax. In other words, the farther you are from the lung, the less chance of puncturing the lung. You can still do it. Don't get me wrong, but like, it kind of makes sense. But what's the drawback of a high insertion? A crummy dressing, right? So the ear is bad and the chest is good. When you walk out, Dr. Dunn was saying an awful lot of stuff. Remember this when you walk out. The ear is a bad place for the dressing and the chest is a good place, right? But to me, this is the main question. What can we do to prevent pneumothorax and maintain an intact dressing? To me, all right, I gave the answer. I thought I was going to. This is the main question to the doctors. Like, in other words, let's stop put our head in the sand and stop talking about pneumothorax for a second. What can we do to minimize pneumothorax and prevent a disrupted dressing? And you're like, on my side, that's on me. But if you can do this, if you can follow your needle through the tissue, You can go as low in the neck as you want. You're not going to get pneumothorax. And if you can't follow your needle through the tissue, you probably shouldn't be doing this procedure. So this is the solution. This is really the solution to the mess on the neck, you know. But following the needle is a technical solution to pneumothorax. And what I mean by that is, it's in your hands. Not so much for CLABSI. CLABSI, there's no technical solution to CLABSI. It's a process. The nurse invades that line 25 times a day. So it's so these hypotheses and theories start with observations or facts. My observation is that these MDs are deathly afraid of pneumothorax. And I mean like, hey mom, there's a monster under my bed, fear. They're scared of this, right? I mean like, so I was, one of the manufacturer executives telling me, oh Jack, we need more data. You're missing the point. It's nothing about data. They're scared. This is fear. It's irrational. They need psychotherapy. This isn't one more paper, you know? So let me discuss generational fear for a little bit. Like I came up in this system. The only thing I ever heard about was pneumothorax. If we got an arterial complication, we might have a mortality and morbidity conference about it. But the only thing we heard about was pneumothorax, right? So if somebody's scared of pneumothorax and they train the next generation of resident, he's going to be scared. So then what do? They don't use the chest. They put it in the IJ. They go high in the neck. He trains the next resident. Where are we with this process? I mean, like, we're in this 50 years. And suppose that person that gets trained becomes the chief of the ICU, maybe the director of the Department of Anesthesia, and he's scared of pneumothorax. Like, he doesn't care about the crummy dressing. Like, this is the culture of the organization, right? I mean, we have to do something about this, and it's not one more paper. So why don't MDs use the ultrasound-guided axillary vein, what they call subclavian? Fear. Fear of what? Fear of pneumothorax. Let's compare, is the fear of pneumothorax rational? Let's compare pneumothorax and CLABSI as complications, right? So we're going to look at these issues here. Morbidity and mortality, extend the length of stay, cost prevention, and the scarlet letter. The morbidity of pneumothorax caused in the hospital is very minimal, very minimal. The morbidity of CLABSI is extreme. Heart, endocarditis, brain abscess, prosthetic hip infections. Because of the mortality issue, we don't even talk about the morbidity of CLABSI. The mortality of pneumothorax should approach zero, right? Done in the hospital, sterile conditions, right? The mortality for CLABSI is 12 to 25%. Like, you're scared of the wrong thing. If you're scared of pneumothorax, you're scared of the wrong thing. Pneumothorax extends the length of stay about 4 days in some papers. I just read CLABSI 22 days in a paper from the Mayo Clinic. It extends your hospitalization by 3 weeks, right? The cost, pneumothorax expensive. You may have to go to a nasty surgeon to help you out with a chest tube or something like that. CLABSI is very expensive. That $45,000 number is 10 years old now, right? Prevention of pneumothorax is straightforward. If you can do this, you're not going to get a pneumothorax. It's like Beethoven singing, you know? Beethoven's playing there, right? But like, the prevention of CLABSI is complex. The nurse invades that line 25 times a day. She's got to scrub the hub, put on gloves, clamping sequence, change the tubing, all that cool nursing stuff, right? Then there's the scarlet letter. If I cause a pneumothorax in Baltimore, you'd know it in San Francisco. The word, oh, Latun caused another pneumothorax. The word would be out, right? But like for CLABSI, who caused it? You ever see an anesthesiologist take credit for a CLABSI? And you never will, right? Oh, that was 5 days ago. You know what I mean, right? And then there's the treatment of pneumothorax. You can observe the patient, or you do this. There's a technical treatment for it.
Mid-axillary line, anterior axillary line. Okay.
Have I ever heard of pneumothorax? Yes, I have heard of pneumothorax. Nobody's ever liked insertion of a chest tube, all right? But the treatment of CLABSI, number one, you DC the line. The patient needs a new line, organ support, antibiotics, it's a whole nother game. You're scared of the wrong thing. But in other words, like put the two conditions together. Okay, procedure number 2, percutaneous IJ vein insertion, right? So basically, here's a paper from a famous medical school in New York City talking about basically what I'm talking about, right? Quality assurance in vascular access. Their analysis at the famous medical school revealed that CLABSIs are most frequently associated with internal jugular vein access. Nobody's surprised, right? Then they tell you why they chose to do it. If I was writing this paper, I would be telling you why I did something different. So their data shows that the IJ vein has the worst infection record. Now they're going to tell you why they had to use it, right? So why they use their reasons for choosing the internal jugular vein, knowing it has a higher infection rate. Number one, their patients are sick. Now, let me go on the record. At the height of the epidemic in April 2020, their ICU was on the 6 o'clock news every night, and the patients looked dreadfully ill. They're no sicker than your patients, right? The second reason for choosing the jugular vein, we're training residents. And I always say, if anybody has a weapon, end my life now. I don't want to live. You're going to teach the residents an inferior procedure because they're residents? I don't get it. I've got a big experience training residents, and I train them my way, not some goofy way. You know what I mean? And then the third reason they use the IJs, the subclavian in quotes, isn't easy. And they're right, it's not easy until you learn how to do it. Then it becomes pretty easy. Nothing's easy until you learn how to do it. I mean, like, I don't know what to say here, you know? So I was at the institution. The great Jonah Kaparis invited me. Anybody know Jonah? Like, Jonah wrote the paper, Midline Vancomycin, but you don't want to be in the wrong side of Jonah Kaparis. You know what I mean? It's just not worth it, right? So she brought me in to visualize what's going on at the famous, you know, place, right? And I'm labeling this how not to do an IJ vein insertion. What I like about this video, the people sound like me. They've got this cool Brooklyn accent, right? Everything, but what I don't like is everything I put in the titles, the writing. Famous medical, right across the street from Central Park, right? I'm there. So, basically they start at the head of the bed. The root of all evil. Where's the dressing going to be when the doctor starts at the head of the bed? It's going to be by the ear. Right? They did use ultrasound. Otherwise, this could have been London, 1969, when they discovered it. They go in the middle of the neck. Right? They don't use micropuncture equipment. Like they're so far behind. An unhappy patient. Note the ear. I don't want to see the ear in my patient. The ear is bad. So he puts in the J-wire, removes the 18-gauge needle, and I thought he was going to dilate without incising the skin. The skin is the natural barrier to infection. I try not to incise it or suture it as much as possible. But no, he makes a nice little skin nick, no big deal. I don't do it, but, you know, that's me. Like, let's just get the ear out of the way. Catheter directed upward. Let's suture it down nice and tight. Let's really hamper the nurse's ability to care for this thing. This patient had C. diff infection. We're going to put him on TPN. And now he's got a catheter by his ear. I don't use heparin. So people, experts, Augie's going to be on this. What's wrong with the dressing? What's that dressing going to look like on day 4? But what's wrong with the dressing? In other words, you guys know, but I'm trying to crystallize for you what the problem with the dressing is. Augie, what's wrong with that dressing? Ear. Yes, ear. It exits from the west side of the dressing and it's near the ear. We want it coming low in the neck, rotated down, so it comes out the south side of the dressing, so gravity's working with you. So now, like, I want you to learn this, so that when you're dissecting it for your doctor, you can go, oh, look, it looks crummy, but say, it's coming out the north side of the dressing, or it's coming out the west side of the dressing. This is how I recommend doing a percutaneous jugular vein insertion.
As low down above the clavicle as we can.
The sound guys are great here, come on. Side of the bed, low in the neck. Ultrasound guidance, decision number 1. I'd ask you what that white line going through is, but that'll be extra credit question. That's the carotid sheath. Thank you, Dr. Ledun. They have to adopt micropuncture technology.
See that, we're nice and low in the neck, we're not in the middle. We're going to put the 5-French micro-introducer over the 0.18-inch wire. We're not going to cut the skin, because the skin is the barrier to infection. This feels like it's going to move the inner cannula and the wire. We'll put a finger over the hole.
I'm going to dilate with 7 French dilator. Okay, it's going to feel a little bit of pushing out. Skin is the natural barrier to infection. I try not to suture it or incise it as much as possible. Going smoothly. You put this into about 19 to 20 cents because the nursing kit, where would you rather care for this catheter, the neck or the chest? One enlightened nurse. That's where it starts, you know? All right, back to the world center, the epicenter of venous depletion.
Side of the bed, roll it in there.
Yeah, this way.
Training course, and I can tell you, if you want us to do this, we need to change all the trainings.
Yeah, the training course is different.
And we were in the class.
That's the HHC course, so maybe this course should be.
So, it needs to go there.
Like, there's been a lot of advances over the years. But if we don't, like, nobody's in charge, like.
Okay, so the course doesn't teach the posterior approach. They teach the stick high.
Head of the bed, hide the neck.
Straight line to the.
And the point is that it gives the nurse something suboptimal. If you do that, the nurse is
Like, who's lecturing here?
they haven't done the issue. The relationship between the insertion and the nurse care. Has that ever come up in the course?
No,
Like, try listening to me a little bit, you know what I mean? Like, all right, so low internal jugular vein. Instead of fear, like Franklin Roosevelt, the only thing we have to fear, right? Fear is irrational. It has risks and benefits. Forget fear, right? What are the risks of a low IJ puncture? It's proximity to the lung and probably increased chance of pneumothorax, right? Until you learn how to follow your needle. But what's the benefit of it? An intact dressing and a decreased CLABSI rate, right? To me, the benefit far, far, far outweighs the risk. It's not fear, it's benefit and risk, right? So what can we do? This is the main question again. What can we do to prevent pneumothorax and maintain an intact dressing? You got to learn how to follow your needle through the tissue. It's like, it's the main thing. And if you can't do this, you shouldn't be doing the procedure. I think the doctor should step away and let the nurses with their experience do this procedure, you know? So the ear is bad, and the chest is good. Like, all right, moving on to the third procedure, percutaneous axillary vein, right? What happens after a central line is inserted? It is given to an RN to use and to manage. Central lines are nursing tools.
Start, nurse. I could put this catheter in his neck or in his chest. Where do you prefer to care for it? The catheter exits from the chest or exits from the neck?
From the chest.
Why?
Because it's easier usually to dress in a lie flat.
Thank you.
What I like is the inserter asks the teammate, the nurse, who owns the line for 99%, where does she want it? It's more important than what, like, some idiot that's putting it on the patient's mouth because he went to medical school, you know what I mean? Like, in contradistinction to the internal jugular vein, the ultrasound-guided axillary vein is standardized at the highest level. You see this one here? All the axillary veins will look like that or have the potential to look like that because of the real estate of where they are. That's standardized at the highest level, whereas the jugular vein, you can put it in 10 different configurations and 9 of them are crummy, right? So, back to the world epicenter. You know, the sort of chief of surgery thought that he could be in the lecture here.
Between those ones on the left side and these nice optimal ones on the right side, what is in between? And this is kind of getting to the heart of these little side conversations, right? So knowledge. I mean, if somebody doesn't know you can do it this way, there's no way you can teach
How long
this.
is subclavian, bro? Are you putting subclavians back in?
We'll get you. Stick with me. Stick with me, okay? A little bit. Hey. You have to write it down. This is what you were telling me. Well, we've always done it this way, right?
We used to know that we
Training.
subclavians.
Like, what happened?
Are we back to
Like,
subclavian?
fear of what?
Buddy, give me a chance to make my point, will you, right? But listen, the chief of surgery at this hospital, like, you can only imagine what they see at this place. You know, what comes in on a daily basis, and they're scared, you know, like, it's like, he's saying to me, "Are we back to subclavians?" I didn't know we left. What do you mean? What do you mean back to subclavians, right? But what does it tell you if the chief of surgery is asking this question? It tells me that this institution and many others is not training people to do this procedure. And that hurts my soul. You know what I mean? So like, then he asked the question, what % of critical care fellowships are teaching the ultrasound-guided axillary vein? Somebody at the Cleveland Clinic, a fellow told me he thinks it's less than 10%. I have no idea, right? But what is the chance that an inserter learns this procedure once they're finished with training? It's not going to happen. You got to, like, you're doomed to practice this the way you learned in your training, unless something big comes along. The thing that came along for me was ultrasound, right? There are many things we disagree about in this field. We agree about this. The optimal location for the dressing is on the chest, and Matt Ostroff showed this paper, right? So, you know, they did a red, yellow, green. The neck is red zone. It's a bad spot. Supraclavicular, okay, if you have to put it there. And the green spot is the infraclavicular area. The ear is bad and the chest is good, right? So Jean-Francois Timsit, the famous French intensivist, asked this question in 2002. Is the subclavian vein the royal root? And he wrote his editorial. Timsit didn't answer his question, but I will. It is. So, what's the evidentiary basis for using the axillary vein? This is the CDC guidelines. They call it the subclavian. The issue is, when you put an ultrasound probe on the infraclavicular area, you can only see the axillary vein. The axillary vein turns into the subclavian vein, as Matt showed, at the lateral border of the first rib. The clavicle's in your way. You can't see it, but you can see the axillary vein all day long. This is the Shea Compendium from 2022, and this is the Society of French Intensivists. Again, Timsit is the lead author. Now, Matt Ostroff showed the visionaries in the field of vascular access, and somehow I made my way onto that slide. Here's an extra, he left out somebody very important. Who wrote the paper that first described percutaneous central venous catheterization? Extra credit, I am not going to deduct. Ostroff's not allowed to answer it first. Who wrote the, like, if you're going to know vascular access history, you have to know the answer. Somebody. Who wrote this paper? No. Robert Aubagnac, anyway, this is Aubagnac's procedure, a blind subclavian. I grew up doing this procedure, and somebody who said, when you pop your needle into the vein, that was Nancy. I used to say I have a, but you're not allowed to say stuff like that, you know? But think about doing it blind. Think about when you get that needle in the vein blindly, you know what I mean? It's like,
Subcutaneous out to do some editing. Edit that the ultrasound visualization of her axillary vessel. You can see the puffing is.
so the gas will preclude the transmission of the ultrasound beam.
This is the one situation where blind stitching is better than ultrasound guided. It's the more simple one.
I grew up doing that procedure. I love that procedure. I won't do it. I won't do it, right? Because, like, if you put an ultrasound, you get two major advances. Number one, you can see what the vein is like, what the vein's suitable. So you know how many conversations I've had with surgeons? Do you know how good I am at blind subclavian anatomic, you know? And I let them bloviate, and I let them bluster, and I believe them that they're good at this, right? But how's the vein? There's two people. If the vein's not suitable, I don't care how good you are, right? And the other advantage is you can follow your needle through the tissue, right? That dashed line is the deltopectoral groove. The axillary vein lives in the deltopectoral groove. Inside of the humeral head in the deltopectoral groove.
Who is that?
The insertion bundle?
I'll tell you to be quiet, okay? Nice skin wheel on the way out. That staying, ma'am?
Micropuncture equipment. There's my needle in the axillary vein. The artery's to the left, the pleura is below.
You have good flow? Then we push down, we just get it to go to 20 centimeters. So we maintain back traction.
I try not to cut the
Getting
skin.
the catheter over the wire. Okay, that's that. All right. So, okay, there's our blue bullseye. So we see we're right in the deltoid rectal groove, right where we marked it. We're doing a medical procedure here. When you cut your bill, all right, so we're going to put on the securing device. So we're going to put this on, and we're going to get the hub. Alright, good. So, here we have an ultrasound-guided right axillary puncture. The dressing's in the right place. Turn your head to the side. We're giving it to the nurse in proper position where she can provide proper care and maintenance. We did not incise the skin, we did not suture it down, and the hub is not all the way into the skin.
So the question is, does that dressing look like it'll stay on for 7 days? And it does to me, right? So the ultrasound-guided axillary vein, right? There's no fear. You know, go to see your shrink if you're scared of this thing. There's risks and benefits to it. What's the risk of an ultrasound-guided axillary vein? Pneumothorax, certainly a risk, until you can follow your needle through the tissue, right? The benefit is a dressing stays intact, decreased chance of infection. To me, the benefit far outweighs the risk. What can we do to prevent pneumothorax? This is the question, like, you know, doctors use that pneumothorax thing as a trump card. Oh, what about pneumothorax? What about pneumothorax? Like, and what are you going to say, like, as an RN to a doctor that's telling you he's scared of pneumothorax? I can talk to him this way if he'll listen, but like, they use it as a trump card, but you have to throw in, like, what about, yeah, and maintain an intact dressing, right? Learn to follow your needle through the tissue. Dimpling, Nancy taught me that term, dimpling, right? 100% chance if you can dimple it, right? And following the needle is a technical solution to getting a pneumothorax, right? So like, there's a technical method to prevent pneumothorax, namely following the needle. There's a technical method to treating it. It's in our hands. I can prevent it with what I do, and I can treat it. Not so for CLABSI. It's not that, there's a whole process to CLABSI, right? All right, sutureless securement and dressing adhesive, right? The infusion therapy standards of practice. Avoid the use of sutures. They're not better. Like, I can't believe the staying power of sutures. And the manufacturers are a little bit at fault here. Like, they're the ones that put them in the kit, you know? So you say, hey, doc, why do you use sutures? They're in the kit. Why do the manufacturers put them in the kit? Because you use them. It's a big, fat, circular illogic, you know? The CDC, use suture. There's no evidence that sutures hold better than a sutureless securement device, but you should put it in. So you know the concept of pistoning? A catheter goes in and out, like, so the ID doctors, nobody likes it when a catheter comes out, but they can't go in. What are you dragging in with it when it goes in? This is pistoning. A friend of mine from Slovenia, an expert at providing care and maintenance. You guys know about Marcy? So this is like, we took off an adhesive securement device and the skin came off with it. All right. And I like to use an adhesive remover. For my family, please use an adhesive remover when you're changing and dressing, okay? Like.
As you're getting it off, the applicator get it down where we need it, right underneath the dressing. The way to get the solvent in the right location.
This is day 7, because we glued it down, put it in the right spot, not up by his ear and his beard and all that cool good stuff, right? Looks pretty pristine to me. All right, vascular access experts. What is a good reason to use the internal jugular vein? And I'm going to have to deduct if you get this one wrong. What is the reason to use the internal jugular vein? I hear and avoid CLABSI. There's one reason, who don't you put PICCs in? Yes, the same reason you don't use the axillary vein. You want to preserve that real estate for grafts and fistulas, right? What is a bad reason to use the internal jugular vein? Let me answer this based on your lack of knowledge on the last question. Patient with tracheostomy. You're nuts. You're out, like, convince me you're doing the right thing if you put a percutaneous IJ in a patient like this, right? Now, has anybody ever, so if they have chronic kidney disease, we want to use the jugular vein. And if they have the trach, we don't want to use the jugular vein. What's the solution to this? You don't want to interfere with their real estate, for grafts and fistulas, right? So you could do the thigh, or you could do a tunneled internal jugular vein, right? So we're going to pay attention to this. I'm going to make a small incision because I'm tunneling. I use a 5-inch 14-gauge angiocath for the tunneling device. The tunnel's not the skill part of this procedure. Puncturing the vein and getting the tip at the cavoatrial junction is the skill part, right? So pay attention. We're going to use the gum mastic liquid adhesive. It all starts the same. It's like a pick insertion, right? We're going to puncture the jugular vein at 9 o'clock position. Micropuncture equipment. 5¼ inch 14-gauge angiocath for my tunneling device.
There's our tunnel catheter going into the tunnel and exiting.
The tunnel's not the skill part.
Introduce it. You feel the pushing. Okay, feels like it's going in properly. So
The rest of this is a pick insertion.
we want to remove the peel away. Push the catheter in, we're going to remove the peel away. We have in deeper, so this is telling us we're at the exact right spot at the cavoatrial junction.
This is a subcutaneous curement device. It works very well. If I'm going to go to the trouble of tunneling a catheter, I want to use this.
Now I'm going to release and deploy.
Darcy, I got about 5 minutes.
Like this, and we're going to put the top on. Okay. Looks good on this side, looks good on this side. And the last thing we have to do, the dressing is going to go.
So you put on the tackifier, you let it dry for about 30 seconds.
I'm going to permit that to dry for 30 seconds. So it's going to go right here. Feel the way it goes down, sticks down very nicely, dress it. So this is what I consider to be modern vascular access.
I want to explain that there's a difference if that mess on the neck gets infected or this gets infected. This was inserted optimally. All the things, single puncture, tip at the cavoatrial junction, the dressing's in the right place. If this gets infected, right, hey, you did you put your head on the pillow, you did everything you can. You make a mess on the neck and it gets infected, like, well, where'd that come from? It's a different situation. All right, let me talk about this. This will be the 5th procedure, the acute hemodialysis catheters. Like, if I walk through your hospital, if I went to your hospital, I can tell you which catheter has the highest infection rate. Pretty arrogant, huh? Because I've never been to your hospital. But it's the same in every hospital. It's the same in every hospital. It's the acute hemodialysis catheter, right? Personally, I've never seen a dressing stay intact from an acute HD catheter when they're put in from the head of the bed and directed upward. Unlike the Medicare, 250,000 times, never. I've never seen one, right? And this is Mackey's paper talking about it, right? So I was lecturing in New Jersey, and the chief of surgery interrupted me. So, like, for me, I like interrupting people, but I don't like to get interrupted. But, he's the chief of surgery. What am I going to do, right? So he's going to have...
I was just going to ask, why do you think the HD catheters have highest? I don't want to say because people put them into the wall, everyone else does it better. Is it the access, is it the patient,
It's an athletic little walk there.
There's a whole bunch of reasons for it. One of them is like this catheter here. This is lipstick on a pig, as far as I'm concerned. This can't be put in the way it's put in like this, and it's folded down so it doesn't wind up in your auditory canal. No dressing with this catheter has ever stayed intact. So it's almost like you're defeated by the equipment. They're heavy catheters, but all the factors.
See, I like this catheter I'm going to show. It's pre-curved in the body kind of thing. All right, so here's an acute HD catheter. A guy that's on a ventilator, endotracheal tube, short neck, a beard. I'm working with a resident. He's doing some, I'm doing some. We're coming from the side of the bed, low in the neck. We're rotating it down. We're going to use the gum mastic, liquid adhesive, and the sponge disc, CLABSI. We're not going to incise the skin. He's got an INR of 4. Look at the probe. Hit the center of the probe, Christopher. Hit the center of the probe. I'll tell you when to look at the screen. You look at the probe. Disconnect. Pinch it. You got to use micropuncture equipment, guys. Sink that. The guy has a beard. Do you think I want this dressing up by his ear? I do not want to cut the skin of this man with an INR of 3.9. 4. Okay, now because it's been dilated once, we should be able to get this appropriate. Put a little traction on the wire. Okay. Okay. Okay, that's 20. The teaching point is, in a patient like this with a short neck, on a ventilator with an endotracheal tube, we do not want a dressing up near the mandible, the hairline, or the ear. We want it down the chest. Nurse, where do you want the dressing in this patient, on the neck or on the chest? Chest. Why? Because it lies better and you provide proper care and maintenance? Yeah. Can I put words in your mouth? Yeah. Okay. Dressing is going to have a good chance to stay on for the 7 days.
Sorry, you're okay, sir.
You're okay.
It's almost over.
Relax.
Okay, I can feel the dressing going on. Very nice, very in a sticky position. So we're going to retract all this. Good. Is that what dialysis catheters look like in your institution? Why not? It's 2025. Change hurts the very soul of these people, right? Suppose there was a study out there that showed the outcomes from this were identical to the outcomes from the lower one. By the way, Ostrov sent me that picture, right? Suppose they're the same. The outcomes are exactly the same. Wouldn't you do it like this anyway? Then you don't need that study. Fear of pneumothorax is not a good reason to make a mess on the neck. I'm sorry, it just isn't. The question comes down to, how do you prevent pneumothorax and maintain a dressing? Learn to track your needle. You can go as low on the neck as you want if you can track your needle. And it's like, I don't want to say it's easily learned, but it's learned. We all learned how to do it, right? Like, we're teaching procedures to people that have never worked. What could be sillier than that? We're teaching these people to do things that have never worked. You know, what planet are we on? This is the United States of America. If you want improved outcomes, there's a way to do it. These are my recommendations. There are hospitals that they look at their infection prevention problem, and you know what their fix is? To switch from one chlorhexidine-containing dressing to a different chlorhexidine-containing dressing. That might be the answer. Maybe, but you got to fix insertion first. Why? It happens first. There's no fixing it with care and maintenance. You can't fix a crummy insertion with good care and maintenance. That's not how the world works. The exit site, the securement, and the dressing are a unit. Get the catheter in the right place, get the dressing to stay on, and put on proper securement, right? The care and maintenance is 99%. They're our partner. The nurse is our partner. We got to give them something that's going to work for them, right? If the dressing's disrupted, you have to change it. It's not enough to change it. Probably coming to the end, huh? Listen, I went a little bit over for sure. I want to thank you for your attention. I really enjoyed being here, and